Hello, everybody. My name is Nikolaos Trikalinos. I'm one of the gastrointestinal oncologists at Washington University in St. Louis with interest in neuroendocrine neoplasms. And today I am joined by Dr. Howe. Dr. Howe does not need any real introduction. He is the professor of surgery at the University of Iowa at Carver College of Medicine. He's the co-director of the Neuroendocrine Cancer Clinic and the director of surgical oncology and endocrine surgery. He has a very long track record, including work in genetic linkage, familial cancer syndromes, and a particular interest in neuroendocrine cancers. Dr. Howe was actually the immediate past president of NANETS and a member of its board of directors, and he's the current president of the Society of Surgical Oncology. We're here to discuss one of his most recent presentations at the European Neuroendocrine Conference, ENETS. Just as a reminder, the University of Iowa is one of the ENETS centers of excellence. Dr. Howe gave us a talk on grade 3 well-differentiated and not well-differentiated neoplasms and what the surgical approaches can be on these. So without further ado, I welcome him.
Thank you, Nikos.
One of the big questions in medical oncology is how to deal with well-differentiated neuroendocrine neoplasms, those who have a higher Ki67, presumed more aggressive biology. But what we tend to overlook sometimes is that there are multiple surgical options for those patients as well. It gets more complicated when we're moving from the localized to the metastatic setting, and obviously from the well-differentiated to the poorly differentiated or neuroendocrine carcinoma histology. Dr. Howe, could you please explain to us what the optimal approach would be in dealing with some of those patients?
And Nikos, that's not something that can be answered really quickly, but I think you bring up the major issues that we're all struggling with, and that is, we know that patients with grade 3 neuroendocrine tumors or neuroendocrine carcinomas generally do very poorly. And the question is, should some of those patients have surgery? Should they all get chemotherapy? And this is what I talked about at ENETS, is the role of surgery in those patients. And I got to say that there are a lot of retrospective studies, but nothing that's prospective, and therefore there's selection bias in all of these studies. I think it's important to really just start with the WHO classification of these tumors, which was changed for pancreas tumors in 2017, where before anything with a Ki67 was considered grade 3. And then they realized that it was kind of important to factor in differentiation. So it's important to know if the Ki67 is over 20%, is it well differentiated or poorly differentiated? And as you know, the patients with poorly differentiated tumors, no matter what you do, they're generally not going to behave well. And these are cases where we've traditionally given chemotherapy. Even with chemotherapy, though, these patients don't live a long time. So the question is there a subset of those patients who might benefit from surgery? And then kind of a little bit better than that are the patients with well-differentiated, yet the Ki67 is pretty high. And if the Ki67 is, say, 20 to 55%, will those patients do so poorly that medical therapy is indicated, or are there cases where surgical intervention is warranted?
Absolutely. I would start with something a little bit on the easier side. For someone with a locally advanced or a local regional tumor that just happens to be, a poorly differentiated or a well differentiated but high grade histology, would you always advocate for surgery up front? I always tell my patients and my colleagues that no matter what we do, we cannot cure those patients. Surgery can cure those patients. So what is your approach? Do you prefer a neoadjuvant approach, or would you rather take out a tumor and then hope for the best, or leave it up to the medical oncologists?
Yeah, so again, these studies that I mentioned that are retrospective, they often lump the well-differentiated with the poorly differentiated grade 3s, which makes them even harder to interpret. And then also they might include pancreas tumors, but also colorectal, gastric, duodenal, and small bowel tumors that are pretty common. Grade 1 and grade 2 are very uncommon for grade 3. So, not only do we have the diversity of histologic differentiation, but we also have diversity of sites, which we have to take into account. But let's just take your question and then say hypothetically it's a pancreatic tumor. If the tumor is well differentiated, but a Ki-67 is say 30%, and it's localized, I think you can make a pretty strong argument to just go straight to surgery. You could also argue if it's very large and is locally advanced that maybe you want to treat that patient with capecitabine temozolomide and try to shrink it, or another option might be PRRT to shrink it if you think it might be difficult to resect. And it might also give you time to see if metastatic disease will show up. But I think you could equally just take that patient to surgery. So you really have both options. If it's poorly differentiated, and again, this requires a pretty good core biopsy where they can look and really make that histologic determination, then, the data that I reviewed for this talk suggested that if it's localized, there may be a role for surgery. Again, you could equally say, let's treat this patient with cystotoxicity or some combination like that for a while and just make sure they don't develop a lot of metastases that would then make you sorry about your decision to take that person through a major abdominal operation. So I think you could give neoadjuvant, although some of the studies show that there wasn't much of a benefit to neoadjuvant treatment, but you could, in a localized situation, take them to the operating room and then treat them with adjuvant chemotherapy afterwards.
This is wonderful. Thank you so much. On the opposite end of the spectrum, let's talk about patients with metastatic disease with a high-grade component, which for some reason have an exceptional response to treatment, with no new disease or with some lesions disappearing while others continue to persist. I know that some surgeons have a more aggressive approach, and once patients look stable, they will try to optimally cytoreduce or eradicate the leftover disease. Is this something that you would advise for?
Yes, I think in the case of well-differentiated, I think you can make a strong argument for that. Certainly, we've seen many patients with pancreatic primaries and multiple liver lesions, sometimes bulky 5-centimeter lesions that after 6 months of treatment may have 2-centimeter lesions. And the idea is if we go in to take out the primary tumor, which we hope will keep them from developing further metastases, we can do ablation and resection of these multiple, say 1 to 2 centimeter tumors. Now, nobody has a good track record to know whether we're actually improving survival by doing that, but it makes sense. And then also those patients can be treated by other therapies down the road, for example, PRRT, if their tumors have uptake. So I think there's a strong argument in the well-differentiated situation. In the poorly differentiated with metastatic disease, I think it's been shown that unless the number of liver lesions are few, and unless you can completely resect all of them, that you're really pushing it, and you probably should not do that.
Absolutely. I really liked the example you gave at the ENETS with the case study where a patient, if I remember correctly, with a pancreatic neuroendocrine neoplasm in the setting of multiple other genetic problems ended up not responding to chemotherapy. The tumor grew and the decision was for surgery, for cytoreduction. I noticed that the patient, by the time of surgery had, I think, one major metastasis that was resected as well, and is currently without evidence of disease. Is this your approach when you resect patients who do not respond to treatment? Do you usually focus on disease that doesn't tend to spread or has not shown evidence of widespread extent if you're going to be looking for that approach?
Yeah, I mean, I don't think you have to necessarily respond. In this particular case, that patient developed a pretty locally advanced tumor that was very difficult to resect. And so we actually probably lost time waiting on that, but it did turn out to be resectable and he's had a good outcome so far. If you have shrinkage of the primary tumor, though, that doesn't necessarily mean that you keep going with chemotherapy indefinitely, because as you know, you can treat people with CAP-10 for a year maybe, but you don't want to keep going after that. So at some point, you're going to get the maximum benefit out of that therapy. And if they haven't developed widespread metastases while you're watching them with treatment, I think it's very rational to remove the primaries, even if you have a good response.
And I know that it is very difficult to produce high quality randomized trials with surgery by the very nature of surgery being surgery. But in an ideal setting, where would you want to see research go? What questions would you want to have answered? Again, in neuroendocrine neoplasms that are well differentiated but high grade, if we had the option to do the perfect study.
Yeah, I mean, I think you could randomize patients to surgery up front versus neoadjuvant therapy. And again, if you're going to continually be limiting the number of patients. So, for example, if you say pancreas, because they might be sensitive to CAP-10, you could give CAP-10 up front and then do surgery versus surgery, and then reserve CAP-10 until maybe they progress afterwards. But with a gastric or a colorectal one, are you going to be able to give CAP-10? What are you going to give in its place? Everolimus, PRRT? I mean, so it'd be really hard to do a randomized trial. And the other thing, as you know, Nikos, is that patients often come with a very strong feeling about what they want. They've done a lot of research. They're very well informed. And it's sort of hard sometimes to get them to randomize to group A or group B.
Fair enough. And quite frankly, a lot of times patients come with your name and they ask about my opinion. So in the same line of thought, PRRT, where do you see PRRT finding its place in patients with usually locally advanced or metastatic disease as a neoadjuvant approach, and just a prediction, obviously?
And are we talking about G3 or everything?
G3 neuroendocrine.
Yeah. Well, I think the absolute requirement, as you know, would be to get a DOTA PET scan and show that there's uptake. So if there's no uptake, well, PRRT is not going to happen. But if there is uptake, then our group here at Iowa has really leaned more towards cytoreduction ahead of time, because we think PRRT works better with less disease. And so we would try to do a good cytoreduction if we're going to use PRRT, and then use it more of an adjuvant. Now, the Italians have used it in a neoadjuvant fashion for locally advanced and potentially unresectable lesions. So I think there is a role for it there. But if you're thinking about, you can use it on the patient once or twice, and where would it best fit into the sequence? I think normally surgery and cytoreduction first and PRRT later. Okay,
that makes sense. Now, you obviously are aware of the fact that many different institutions have different approaches, different aggressiveness levels when it comes to surgery and cytoreduction of patients who may or may not be curable. And this is all the more difficult because not a lot of patients have access to tertiary centers like Iowa, for example. What would be your best piece of advice for a patient who's newly diagnosed and has metastatic disease and possibly with a well-differentiated or high-grade component, to seek multiple opinions, get an evaluation at tertiary center, or just consider surgery up front?
Well, no, I think it makes a lot of sense to get multiple opinions, and not just the opinions of surgeons, for example. In that situation, you want to get medical oncologists, and we have great endocrinologists as well, Dr. Dillon and Dr. Odoricio we work with here, and Dr. Chandrasekhar and MedOnc. And I think as a team, a lot of times it helps for us to just both the two or three of us review the records and talk amongst ourselves about what we think is the best for the patient. And, for a G3 patient with 20 liver mets, well, maybe surgery isn't the best thing for that patient, because again, the studies that looked at stage 4 disease suggested that R0 or R1 resection is probably pretty important in those patients with poor tumor biology. And so those are the patients that are going to be harder to cytoreduce. And those are the people that I would push more for a neoadjuvant approach to make it easier to get cytoreduction and to reach a good threshold of cytoreduction. But I think the importance is a good multidisciplinary team. And as we all know, these patients are very well informed. They do a lot of research, and there's nothing wrong with getting another opinion.
Dr. Howe, thank you so much for lending your expertise and your time, helping us understand a little bit more about where surgery fits in some pretty difficult to treat neuroendocrine neoplasms, the high-grade, well-differentiated and high-grade poorly differentiated ones, an area of ongoing research. We are looking forward to more knowledge generated and to many more talks like this, either at ENETS or NANETS.
Thank you very much, Nikos. It's been a pleasure being with you today.